we'll just start with a couple opening notes and reminders. Welcome to UW Project Echo Dementia. If this is your first time, please do enter your name and where you're from in the chat and an email so Allison can follow up and add you to our community. We're very fortunate to have Dr. Emily Tritschu here today from the VA, a geriatric neuropsychologist who's going to speak with us about gender affirming care. And then Deborah Tillman has graciously brought forth a case. So we're all quite familiar. Everybody can see my screen, correct? Yes?
Well, we're seeing the last closing session slide.
Oh, hold on one second. Let me do this again. And thanks for clarifying, because I was seeing what I needed to see, but I guess you all weren't. So thanks for that, Chris. Now, do you see the Zoom reminder? That's what it looks like to me. Yep. Yes?
Yes.
Yes, indeed.
Okay, great. So thank you for that clarification. So yeah, please do enter the names. If you're in a room with a couple folks, enter the names of all the attendees from your side onto the chat, if you could. And if you're not speaking, please mute your microphone. And if possible, and we understand if it's not, we'd love to see everybody's faces. There are a number of really wonderful CMEs that are ongoing, CME accredited UW echoes in a range of areas, as you see here, from traumatic brain injury, behavioral health, on the first and third Friday of each month. There's also a UW Psychiatry and Addictions Echo, which is on Thursdays. And then there's a behavioral health training series on the third Friday as well. In addition, there's a really great telephone consultation for folks who are caring for people with complex pain, medication regimens, particularly those who are on high-dose opioids. So this is a provider consultation hotline. And then there's also a CME accredited case conference series through the UW Telepain series as well. And these are all CME accredited. For any presentation, we really take HIPAA very seriously, so please protect any private health information during our sessions, nothing that could reveal private personal information regarding patients or families. And all our sessions are recorded. They're available on our website. And please do fill out the survey so we can continue to improve this programming. So this is our list of our upcoming sessions, and stay tuned because we're going to start adding on beyond June very soon. And if you do have a case that you want to bring forward, as they're really an essential part of our community learning, do reach out to Allison Schreier. Thank you. We have CME accreditation through University of Washington, and we have nothing to disclose, neither the presenters, nor the planners, nor anyone involved in today's echo. And if there is any financial relationships, we really take this very seriously, and they're all mitigated and disclosed in other talks. So this is our hub team. I'm fortunate to co-lead this effort with Dr. Christopher Rhodes, and you see our smiling faces here. And we're just so grateful to be part of this larger community with throughout the state of Washington. And wow, launching in June 2020, we've provided over 1,000 instructional hours, and well over 70% of our survey respondents said that they would change the practice based on these learnings. And so please do continue to participate, engage, and share and spread this work. Oops, sorry, let me go back. What happened here? Excuse me. Hold on here. What's happened? I'm going to, you know what, I'm just going to introduce that we're so fortunate to have Dr. Emily Tritschu here today to talk to us. And she's a geriatric neuropsychiatrist at the VA. And thank you, Emily.
Great. Thank you so much. I'm going to see if I can get my screen sharing to work here. Can you see it? Anyone can just give me a thumbs up. Thank you. And it just, I'm a geriatric neuropsychologist. So without that MD, I'm not, basically just remember, I'm not the person you want if your heart is giving you pain, unless it's emotional. So thank you so much for having me here today. I don't usually start off a talk with apologies, but I am going to do so today, in that I've been coming out of a little bit of an illness. And so I'm definitely am feeling like I pulled this together, but this is a topic that normally I could speak on for an hour, 2 hours. So trying to kind of condense and pull out some of the nuggets for the short presentation today was hard. I'd like to talk about affirmative care for transgender and gender diverse older adults, although it's not necessarily specific always to older adults. And as always, the views and opinions that I present are mine and do not necessarily reflect or should be taken as official policy of the U.S. Department of Veterans Affairs of the University of Washington. So I think it's important to start off with just some what I consider basics at this point, but were not basics when I started on this journey a number of years ago. The gender unicorn stands here before you. And let's take a moment to do this review and realize and remind ourselves that there are independent, sometimes related entities for individuals that we as a society conflate all the time. I don't know if you all can see my mouse or not. Hopefully you can, but I'm circling the rainbow up here. That's a thought bubble to represent gender identity. That is the sense of one's knowledge of what your gender identity is. It could be female, male, it could be other. There's an additional component to that often, which is the actual expression of one's gender. These are these green dots over here to the left, and that can be more feminine, more masculine, more other. These things don't always perfectly align. There are plenty of cisgender women who are not overly femme, and there are plenty of trans women who are super femme. There's just not a rule that things have to match in a certain way. This can be contrasted with one's chromosomal sex, the sex assigned at birth. And then, of course, this is definitely separate from physical and emotional attraction, one's sexuality, which can be aligned in different ways as well. So a little more of that background terminology. I use the term cisgender. This is for individuals for whom their gender identity is equal to what their biological sex was as it was assigned / assumed at birth. In contrast, one could be a transgender man, a man who is assigned female at birth, or a transgender woman, a woman assigned male at birth. And when I use the term gender diversity, I'm using it as an umbrella term. Which can include trans folk, but really anyone with a non-conforming gender experience, identity, or expression. So if you think about gender non-binary, that is not just a neither nor, not male, not female, not woman, not man, but it can encompass other aspects of gender, agender, gender expansive, gender fluid. One's gender identity may not be fixed. And when I use the TGD, the transgender and gender diverse label, I've essentially chosen this to represent that larger umbrella term to include not only transgender individuals, but those who are non-binary and those with additional diversity and expansiveness. Now, I'm choosing certain language in this talk, but please remember that there are generational, cultural differences in how different folks refer to themselves. And at the end of the day, however someone wants to call themselves, that's what's right. That is the answer. This is pulled from a paper a group and I published last year. I won't read through all of this. The top 3 are essentially what I've just hit on, but keeping in mind that for many individuals to live their correct gender identity, they may engage in different therapeutics to help affirm their gender. It may be hormone therapy. It could be a gender affirming surgery, different things like that. And then in the middle here, I want to highlight something to try to avoid, and that is misgendering someone using the incorrect pronouns, gender, other nouns. And then dead naming someone is when you call them by a name they no longer use. In many cases, that is their birth name. And as you can imagine, these are insults, whether they are meant or not meant to be aggressive. They are microaggressions. And so part of affirming care is to do our best to avoid this. It would, exactly. So yeah. So let me jump on from here. So who are we talking about? How many folks are there out there? There are very good estimates. I'm presenting some here, but I think you can imagine that in times past and even now, one's willingness to share with people you don't know can range and may be very different, especially in different parts of the country. So a number of estimates that are from the last decade have seen about 0.5% to maybe even over 1.6% in United States samples. That 1.6 was actually from a younger aged sample concentrated in Massachusetts. That was a fairly liberal part of the state. The 0.5 is from a much larger study that was essentially administered a big questionnaire sent out randomly to adults across the United States and has a very low number coming back. We do know that there seems to be about 2 to 3 times higher numbers amongst U.S. veterans. This is one of the reasons I developed an interest in thinking about affirming care, and especially in my field of neuropsychology, conducting neuropsychological evaluations with folks who may be TGD, and well, personal reasons as well. But I could do a whole talk on what are the various reasons. Why would the estimates, why would the population be 2 to 3 times higher in veterans? But you yourself might be able to imagine some of the reasons why people would end up either choosing the military or for various reasons. So keep in mind, though, that being transgender and gender diverse is an aspect of one's identity is certainly not the only aspect. Gender identity is not necessarily static across the lifespan, and transition is a process, and it's not always linear. So there's been a number of other surveys and things trying to get more accurate estimates of the population size in the United States. This paper from 2017 was a meta-regression. It had 5 different surveys included in its sample. And then from that, because some of them are recurring studies, they basically were able to have 20 quote unquote samples that they pulled from. The problem is that 70% of those samples were fairly narrow bias samples, either from college students or adult inmates, whereas only 6 of the 20 were from the general population. Regardless, their finding in this study is that there has been an increase over the past decade of the numbers of folks in the transgender population. And so if I had a longer time for the talk, I would ask, what do you all think could explain these? I have had someone jump up in the audience and say it's a fad, which is wrong. I would remind everyone that in the history of left-handedness, there was a time where it was thought that very few people were left-handed. It was highly stigmatized. People who were found to be left-handed were forced to be what they are not, to try to be right-handed, sometimes in very painful ways. We know now that that is bad for the brain. And you can imagine a parallel here for folks whose gender identity is not cis. There's much stigmatization. In some ways, we're entering a period where it's okay to think about one's gender identity and question it and maybe not have it aligned with sex at birth. On the other hand, we're seeing nasty backlashes in many areas of transphobia. I would imagine if we could live in a society where the stigma stayed reduced and consistently so, that we would see the population percent level off and really actually have a better understanding. So for folks that are transgender and gender diverse, there are some unfortunate, or horrible, not just unfortunate results, though, of the stigmatization over time. Folks who are TGD are 4 times more likely to earn less than $10,000 a year, with 2 to 3 times higher unemployment rates than their cis counterparts. There are alarming rates of verbal harassment, physical attacks. 63% of folks have experienced not just small acts of discrimination, but serious acts of discrimination. And of those, 20% were acts of discrimination that had catastrophic effects. This can be significant injury. This can be loss of home. This can be loss of job, other things of that nature. Also, in addition, for folks who are TGD, there's a real health disparity in access and equitable care. 23% of respondents from this James et al. Study from 2016, it's not just that they didn't go see a doctor for regular annual visits, like so many just take for granted. They didn't go see a doctor when they actually needed care because of their historical experience being mistreated as a transgender person. 19% reported actually going for medical care, but being denied it. And I'm not talking about gender affirming care. I'm just talking about regular old medical care. For those seeking gender affirming care, 91% reported wanting the various things like counseling, hormones, hormone blockers. And of those, only 65% reported getting access to what they were needing. In addition, there's research. This is one I could also go into for a while, and it's better covered probably in a pediatric adolescent expert, but there are a number of different studies, not just this one, that suggest that there is an overlap, or can be an overlap of neurodiversity with folks who are transgender. So when you're working with older adults who are trans, consider that there may be undiagnosed autism spectrum traits or characteristics. In other areas, overall, there are higher rates of depression, smoking, substance use disorders, and tragically, much higher rates of suicide. 41% in studies have had an attempted suicide. That's versus just 1.6% in the sort of quote unquote general cis population. The thing that really could change all of this is that there's so much work out there that supports that affirming hormone therapy and other affirming care can result in improved psychological function and notably better quality of life. So the access, though, to medical affirming care has barriers, you can imagine. At the very least, it typically requires a mental health assessment and the either confirmation or a diagnosis of gender dysphoria, which is from the DSM, the Diagnostic and Statistical Manual for Psychiatric Disorders, version 5. Additional considerations, especially when working with older adults, would be whether there's medical decision-making capacity. And a lot of times the timing of a hormone therapy or hormone replacement therapy might be mitigated by someone's current social circumstances, housing, and other stability factors. So I'd like everyone to keep in mind that transition is not just a medical transition. Often for many folks, there's a social transition that occurs first. It could be including any of these things: changing one's name, one's presentation, changes in social media, and how one navigates the world around you. But it's very variable for different people because some people read more or less as their gender. And that can lead to many different circumstances and experiences for them. Privilege versus marginalization can come into play. There's a lot of intersection with race, and there's a great deal of trans misogyny amongst this for this group. Positive, there is increasing, it seems, numbers of folks who are connecting with community support. These can provide important resilience factors. Maybe it's not their blood-related family members, but other social support peers, their minority community. These all can provide strong supports for coping and internalized resilience. So I've taken a while here to get to, well, what is affirmative care? And I just think at the end of the day, it's about practicing cultural humility. As care providers, either healthcare providers or just care providers for loved ones, we have a duty, I think, to maintain an interpersonal stance that is other oriented. We are here to serve them. And that needs to be in many areas, but especially when it comes to cultural identity, features that are important to the individual we're working with. We need to see the people for who they are. We want them to be able to share who they are with us. And I'll put it as a positive. I think it affords us an opportunity to push ourselves to overcome our biases. We all have them, conscious and unconscious. I'm not promoting this project implicit from the Harvard EDU website, but it is a way of sort of using implicit association tests to kind of check oneself on some different attitudes, beliefs, and stereotypes. Although I would argue that just because something comes up that you don't have a bias there, you may still have it in just a different situation. And then importantly, Hayes developed the addressing model. It's been around for quite a while now to help folks identify cultural influences and to seek out and recognize intersectionality. I'm going to try to hit on this kind of quickly. The model framework and overview, each of those letters addressing stands for different cultural or individual characteristics. And this calls out basically that for each of these, there are those that are in power and those with less power. This is not always a majority minority thing, other than that the minority part is having less power. So when we think about working with older adults, we know that these age features give less power. We're often working with older adults who have disabilities, whether they are from birth, or they've developed due to stroke or dementia or things like that later in life. They may have religious and spiritual status that has less power: ethnicity, race, socioeconomic status, sexual orientation, indigenous heritage, national origin, and then in this case at the end, gender is a bit what we're focusing on today. I would also say that another aspect of diversity can include military background and veteran experiences. I'm not going to read through this, but I wanted to call out this Jones et al. Article from 2015, which has some terrific questions that you can use to interactively complete either yourself to think about your own power or lack of power in certain situations to understand your cultural humility, as well as to do it with coworkers, support staff, and if you have trainees as well. Another important component to think about when providing affirmative care is minority stress. This is a version of the minority stress model from just a few years ago, focused on the LGB community. And just really recognizing that there can be this sense that there's more pathology amongst those from these marginalized, minoritized communities, but that's not inherent. That's a cultural phenomenon. That is a pathology of our society that creates this and creates a system of stress for these individuals. I won't read through the whole thing. I really hope if anyone has interest in this that they'll read a little further. Testa and colleagues also created a version that gets at gender minority stress. And what I really just wanted to highlight here is think about it when you're working with older adults who are TGD. There's really no chance that they haven't experienced gender-related discrimination, gender-related rejection, victimization, and non-affirmation of their gender identity in their lifetime. These can have additional stress factors, whether it was from hiding who they are, anticipatory negative expectations, even internalized transphobia. Now, on the other hand, there's resilience factors to consider as well, but all of this has a direct, a large interaction effect on both physical and mental health. So how can we have affirmative interactions? Well, just sit down with your crew, whoever they are, in your clinic and in your home, and brainstorm. How can you make things welcoming to all? How do you use methods of address that are non-gendering? Especially think about your forward-facing information. It's kind of shocking how many practices have like forms to fill out if you want to ask about, can you be seen, that have gendering and non-affirming language in them. We want to get rid of that. Um, uh, the language does evolve quickly, and that can feel intimidating at times. Once you meet someone, your goal is to reflect the language that they use for themselves and for their experiences. There are certain things that are kind of broadly acceptable: transgender, referring to hormone replacement therapy, sex assigned or assumed at birth. However, there are terms like transsexual, or saying that someone identifies as a woman. That's horribly dehumanizing. Saying someone's pronouns are their preferred pronouns when it's really their pronouns, or referring to someone's quote unquote real name. These all can be incredibly hurtful. So if you are in a clinic and you're working with folks, really take a deep breath. What do you actually need to know? You might need to know a lot of the same things you need to know for all other patients. You might need to ask a little bit more about demographic information, ask about sex and gender, oftentimes in this order, and do it ahead of time. If you mail out forms, make sure the forms don't have a checkbox, male or female, and nothing else. You might need a little extra time in your interview, especially for thinking about impacts on social, educational, occupational experiences, querying for trauma and discrimination, while not assuming that someone's experienced it, but they likely have. It's just how it's affected them that you're trying to get at. You also want to ask about medication, surgical history, if relevant for the care you're providing. I won't read through all of this, but there is a lot to think about. There are studies of greater HIV positivity in transgender women, especially those with intersectionality with race minorities. And while these can be risk factors for cognitive changes, there's also really unclear long-term effects of hormone therapy, as you all know, for any population. So just to hit on that, it does appear that there is some increased prevalence of cardiovascular and cerebrovascular disease in events, less so for transgender men versus transgender women. And also with oral contraceptives, when one is on hormone therapy, there can be a higher risk for cardiovascular events versus even cisgender women who are on oral contraceptives. There's also studies out there that talk about increased mortality, but those really haven't been particularly well done, and that can possibly be explained by suicide rates and also AIDS in this population. As I mentioned, there's I didn't mention this, but there is really unclear findings about the hormone-sensitive cancer risk in the transgender and gender diverse population. At the end of the day, folks who are transgender and gender diverse are less likely to go in for preventive care. The screening guidelines that exist, even if these folks show up, are totally designed for cisgender patients. So there's a lot of room for change. Thinking about aging and cognition, you're probably like, gosh, I thought she was going to talk about this more, but I wanted to make sure the foundations were there. I, as a neuropsychologist, I always individualize my clinical cognitive evaluations, but I have to go even further when I'm working with a transgender older adult. There's no normative data information, and most of these folks have either been actively excluded from research and normative data sets, or were excluded simply by the lack of inclusivity to be part of this history of research and collection of aging data. The gendered normative data at any age is problematic in my mind, but it's particularly highly problematic in aging. For folks with dementia or other cognitive impairments, just take a moment here to think about additional considerations. If someone is having, say, has a classical sort of case of Alzheimer's type dementia, they may be losing those more recent memories of success and years lived as their true self. That could really have a very negative impact on their mood and on their other features of resilience that they've built up over time. Experiencing losses of independence for instrumental activities of daily living is going to be triggering and isolating potentially for folks. Social isolation amongst LGBTQ older adults is much higher than in the cisgender straight population. I'll highlight the work of a researcher at the University of Washington in a moment who's done a lot of work in this area. Even moving further along, say on the dementia spectrum, losing your independence for maintaining your basic activities of daily living are very likely, unless you're in a really supportive environment, going to result in a loss of your external identity and expression. And this could be highly debilitating for an individual and for their quality of life. There are laudable goals out there to try to avoid polypharmacy in older adults and be de-prescribing, but I would argue that should be harshly balanced with a what matters approach. What are the values and goals of care for the individual in front of you? And at times it may be worth keeping hormone therapies and other therapies that are gender affirming, despite sort of the quote unquote best medical guidance. Also, I think just overall, we've got to strive to improve the inclusivity. I don't mean to call out senior centers in general, but a lot of them are in older buildings. The bathroom situation is not ideal. And then thinking about various levels of assisted care and what essentially can become an institutionalized setting can be very non-affirming for TGD folks. Also, when we think about the systems of care that are in place and caregiving, we really need to embrace alternative versions of family, of community, and the types of caregiving supports and resources. LGBTQ folks in aging are much more often to have a non-family member as their caregiver. And having the ability for these people to designate them as their person and to have them involved in their care just as a family member would. So unfortunately, when it comes to this entire area, there's a real paucity of research. A lot of the research that's out there is pretty riddled with bias, especially things of like, oh, brain morphology is different in trans men versus cis men. And then it's getting so much better, but there's been really limited training in medical graduate programs, other graduate programs, postgraduate clinical experience. So we need to do everything we can to improve the affirmative care and cultural humility of generations. And that goes for people my age, pushing themselves to learn and grow. And for better designed research, we've got to stop conflating gender and sex. They're not the same. There's a lot of research out there that makes comments about women this and men that, but they can't really say that. There are a number, this is not an inclusive, a complete list, but I have commented a little bit on the notable work of Karen Fredrickson-Golson, who's at UW School of Social Work in the area of aging for LGBTQ folks. Also, Jason Flatt and Shayna Stites are active in the dementia and aging area, and there's a great Rainbows of Aging project. I'll save this as a PDF that'll have hyperlinks working here. I think I have to wrap up pretty soon. I also have a table from that paper published last year that has some additional resources. Trying to keep up with truly gender inclusive language requires checking out websites once in a while for the folks who are posting it to keep yourself more aware and not falling into old practices. I highly recommend this YouTube video by Dr. Courtney Wells, Loosening Your Grip on the Gender Binary. It's tremendous. They do it in the stands at Wrigley Field in Chicago. And just there's a lot of humility and humor, but hard truths that are shared in that video. And also in your slides, you'll have some organizational guidance and standards of care. I want to be careful. There's lots of, even within the trans community, there isn't just one voice. So while WPATH is there as kind of the leader of the international interdisciplinary goal of providing evidence-based care, there's still many aspects of dissent within folks in this community. And so being careful, I'm trying to be careful not to just promote one thing blindly. And I do think the American Psychological Association and even the Veterans Health Administration have done a lot to try to be at the leading this charge. So I had this little bit of pitfalls, best practices. We all want to avoid misgendering folks. We all want to avoid overly medicalizing the transition for individuals. It's much more than a medical process. It's the one's whole life. We also do not want to ignore intersectionality and other types of acquired marginalization that can occur. We should make no assumption about what someone's actual goals of transition or the steps taken, what they are. There's a tendency to gender medical procedures, having women's health clinics. And then unfortunately, it's hard, but there is a tendency towards voyeurism. And so trying to check yourself and think about whether you really need this information or are you just more curious for yourself. And then the best practices is to really engage in transparency with patients. And really consider the utility of information you're gathering. Does it all need to go in the chart? Maybe not. Respect for individual. We want to do no harm in our clinical care, but also in research. Have walk forward with cultural humility. And at the end of the day, talk to the stakeholders, talk to trans folk, listen to their voices and those of their allies. Keeping in mind that at the end of the day, silence is complicit. You have to actually demonstrate the affirmative care, not just say it. So that is that's my whirlwind. I'm going to try to think I'll take my camera off here. If I hit escape, and then. All right. I hope there's some time for questions.
Dr. Trichu, thank you so much for that amazing talk. And you can, if you want, leave those questions up to prompt discussion or take them down either way.
Let's see if I can do this. I lose seeing you all when I share.
Yeah, so why don't we just leave them then we can just see one another. That's okay too.
Okay, well, I can, yeah, I think the main, here as I try to stop sharing again. Computer doesn't like fast changes. Are there any questions right off the bat?
This is, and I'm going on, I'm off camera, but I just wanted to say thank you so much. And I will definitely share the slides widely. I know so many people who will really benefit from this.
Thank you. Yeah, I'll send that, and the hyperlinks will be in there. And
yeah, that was amazing. Thank you so much. Also in the chat, and so many resources and links and opportunities to take deeper, learn more. And
thanks. Yeah, I don't know if I think the area that I didn't go as in depth in that some folks may have wanted is in the dementia area. I think the challenge there is that there isn't a lot out there. I think there's some acute case presentations in the literature. I think the problem is that, and I'm a geriatrics person through and through, I just don't think, it's interesting because I think the geriatrics community tends to be a patient-centered, that we've sort of had a real team approach for a long time, that we kind of fell back on pushing forward in some of these other areas, having but more team-based care and things like that, that we really do need to take a look around our care environments and really think about what we're doing that is affirmative, and across all of these areas of cultural differences. So that's what I hope people will really think about after this, is to take a look. And then let's see, Dr. Rhodes, did you have a question?
I think you're muted, Chris. Chris?
Yeah, indeed. Yeah, I was just curious if you have any tips or words of wisdom for working within systems to make some of those changes. Some are more bureaucratic and, takes 3 months to decide on letterhead, so I'm wondering, any advice there, things that you found to be successful?
Yeah. Well, as you point out, it can sometimes be purely bureaucratic, in that, if you point out something to someone that they don't disagree with you, it's just that there's like different steps and approvals that have to happen. But I would say this, it's being a leader of that change, and just always being the one who's going to point it out. I was kind of obnoxious. I was on a promotion criteria review committee for my department, and they had done this great job of recognizing that there can be academic excellence in public service and not just in research, not just like in the track I'm in, clinician teacher. But they did all this work to redo all the criteria and write out the guidebook. And I looked at it, and the first thing I saw was it was he, him, or she, her. And I felt like that sticky widget, but I just said, I can't approve this. This is just the smallest change that just makes a big difference. Let's change that up. There's no reason it can't be they, or them for all. And not be excluding. So yeah, that's kind of what I've tried to do. I can't say that I've had any success with major system changes. I've fought a little bit when there was a new building being designed for the bathroom situation. That was less successful, although there was greater recognition of having more individual bathrooms. It's just that they're harder to find. So they are there. They're just not where the bank of men-women bathrooms are. Although personally, I just always have had this sense of, I just don't think that public bathrooms should be gendered. I don't know why you just can't have stalls and whatever else you need, but oh well. I don't know if anyone here's had any successes or challenges trying to engage in some change. Maybe not. I think sometimes.
I was just going to jump in.
Thanks.
Yeah. So I think, so I work with Dr. Eisenberg here at Swedish, and I think one of the benefits that we had was that we're creating a center from the ground up. And so we have a lot of say in the pamphlets that we order and things that are on the wall and what, a lot of what's surrounding our clinic. So I think we both feel very positive about the materials that are around us that we give to patients, but we also had, again, the benefit of starting from the ground up and not necessarily going into a clinic or a department that was already, everything was already set. So on the one hand, it is nice when you have the luxury to be able to do that and review all your materials. And we try to do that, I feel like, on a regular basis, where we, our last meeting recently, we reviewed our clinical intake form, and looked at things that we could change. So I think that's helpful, but I do think it's hard when you're a part of a very large system where so many things are already set in their ways.
Absolutely. I mean, I think of like essentially at the VA, the community living center is essentially like it can be a longer stay care location. And we're in a building that was, I don't even know how many gazillion decades old it is. The challenge is that when someone's on the unit who is a trans person, they get treated well, but they get treated like the exception. right? There's these different things that are done for them that hold them differently than the other folks on the unit. And obviously it's better to try to accommodate people into, but we shouldn't want to be accommodating. We want to be affirmative. Like there's just these subtle things that can make a big difference. And so, I think, even not that I've had much success with this, but just calling it out as such, like, hey, this is what we're stuck with. Really sorry, this kind of might not, we wish we had a better setup. Whenever we rebuild, we'll do better, right?
Thank you so much. Wonderful.
All right. Well, I think I'm supposed to wrap up now so you can do your case.
Okay. So thank you so much again.
Thank you.
And I know that all of us are going to be accessing, what had happened here? The resources. What is going on with my screen sharing today? It's just like never. Try it again. I'm so sorry. I don't know what's happening. Very odd. All right, we have a case. Just a minute. I'm sorry, my computer is acting up, it seems. Okay, here we go. Hold on. Oh my goodness. Thank you all for your patience. We're going to have a case with Deborah Tillman, and thank you again, Emily. Let's see. So I see it, but you all don't, right? Give me one. There we go. Okay. Please confirm that you can see this. Yes? Yeah. Okay. Yes? So thank you. And thank you again, Emily. Yes. And so Deborah, thank you for leading us through this case presentation. We're very fortunate to have you. Let's do it. Ready?
Yes, I am. Thank you. Yeah. This case is maybe a little bit different because it focuses more on non-traditional medications, or standard medications might be the better way to go about it, and lifestyle modifications, which we often talk about, but isn't really the focus of most of the care that I see being suggested. This is an 86-year-old gentleman who prefers to do things like use CBD products and naturopathic, and so that's the focus of this presentation. He is divorced, no significant other, but has attentive children, retired teacher. He remains a lifelong physically active person with yoga several times a day, push-ups, and walks extended periods. Very limited alcohol use, was a brief tobacco smoker. There was a short-term marriage there where the spouse smoked, but is many decades of marijuana smoking, but has essentially transitioned over to a CBD edible or other products. Okay, so if we can just go ahead and go forward. About 8 years ago, there was a marked decline in that physical ability, but still tries to be as active as possible. Last year, there was a recognition, no longer able to take care of his own single family residence. So he did reluctantly agree to move into a retirement community. It's not quite assisted living, but there is 3 meals a day and some oversight. And just the removal of any responsibilities for home care, which were overwhelming for him. Remarkably, he doesn't recall this period. He needs to be reinforced that he was the one that chose to sell his home and move into the facility. He has had symptoms of mild cognitive impairment, but really a history of secrecy about his symptoms in this effort to maintain the independence. He has reported these periods of intermittent no recall of events, And then kind of one time period where he felt like he was seeing some visual hallucinations. He has what I would call undiagnosed post-traumatic stress disorder and anxiety from being a victim of child abuse. Pretty significant. And he continues to have interaction with the siblings from that time, but they always seem to be very stressful interactions. Other things that have been present since childbirth are this AFib, which he's had since childhood, and he reports that he had German measles. In the last couple of years, he's developed an uncontrolled hypertension, including one crisis where he was well into the 200s. I believe when EMS was called, they found while he was supine 210 over 110, something to that effect, with some deficits that resolved as the blood pressure went down and an inpatient stay. He also has history of a neurogenic bladder, self-caths, and this was the result of him not reporting to anybody these symptoms of urinary retention. He, as a history of a retired teacher, he had that instinct to hold his bladder for extended periods, but this was after he had retired. He's not happy about the self-cathing, and there are infrequent but pretty significant UTIs where he has this gradual altered mental status. So when he does have some of these periods of prolonged memory loss, there's always this concern that it's another UTI. Also history of sarcopenia, the focus on trying to be as healthy as possible, but going into the extreme of eating just things like raw nuts, fruit and vegetables, really no true protein sources, despite his very physical daily regime. From that medication, I had forgotten there's some glaucoma there too. He does have eye drops, prescription eye drops to control his glaucoma. And I think part of the reason why he's accepted a prescription for that, but not for any of these other conditions, is that he sees most prescription medications as poison. He prefers to do things naturally as much as possible. A year or two ago, he did decide to start taking an aspirin because it's based on a natural product, and he could see that direct link. He also takes several supplements every day. Overall, his lab values have been totally unremarkable. They look like a great healthy person in their 20s or 30s. He had a long time primary care provider for several decades that he had built up a really good trusting relationship. But when he started to have the uncontrolled high blood pressure, there was a real breakdown in communication where the PCP essentially told this person, I can't help you anymore if you're not going to take these medications to bring down your blood pressure, decrease your risk of stroke or heart attack. And so this patient had to go to a new PCP who was even worse, reported to have not even made any eye contact, just in the room for a couple of minutes and then left again. And so another switch, but added a naturopathic provider where there's been some good feel to that beginning relationship. But I was told that naturopathic clinic in turn had him purchase from their sources, their in-clinic supply, several supplements that he already had at home. So there's this little bit of a feeling like they're taking advantage of him to some extent. And I don't know really how bad his, in the moment of stress, his cognition is to say, hey, I already have these. I don't need to buy these again. So in his collection of containers of supplements, there's many overlapping, and he's starting to get confused about what to do with those. The one thing that's been fairly consistent is the marijuana use over his life. And as CBD products have come onto the market, he has tried them out. I don't think that I was even aware that there are CBD drinks that you can buy in a thrift way now. So there's definitely products that are easily available. And what research I've done is that many people use them for anxiety, for post-traumatic stress symptoms, kind of self-medicate. And in reflection, I think that that's what he has been doing for much of his life. So that's kind of a summary.
Thank you, Deborah. So
Mhm.
really a very challenging situation where that relationship and the trust, it sounds like, was really not, was hard for him, and was hard in that context to develop over time based on his beliefs and not feeling perhaps heard. I'm curious from our community, what additional questions might you have for Deborah?
Maybe I can expound a little bit on my desire to know more. When I go on to websites that talk about things like the CBD, the spectrum that you can purchase it on, I don't know much about it. It has never been presented to me as that I'm aware of as any kind of a continuing ed topic. And yet all of the websites, such as the Alzheimer's Association, say you should talk to your general practitioner about this to get updated information and decide for you, what's best. What I have told my family members who are concerned about their loved ones, especially with dementia and uncontrolled anxiety, is that it needs to be kind of a word of mouth. Find a good brick and mortar store that you've heard of through your friends and family that have reliable products. And then through word of mouth, find one that's going to work for you, but it's probably going to be expensive or work for your family member. And I can't prescribe it, which gets very complicated for anybody who is in an assisted living facility, let alone secure memory. So we kind of get back to this position where family members know that there's possibilities there, but I can't really assist them.
Mimi, please.
Yes, Deborah, I have a question. On the
Mhm.
products that he uses, does he use them kind of as maintenance therapy, or is there something that triggers his taking some product, edible or whatever it is? Or how effective are they? How does he report that?
I would say that he continues to dabble, that it is not a daily use. Since he moved into the retirement facility, he hasn't been able to smoke. There's no smoking allowed. So if he was going to smoke something, it would have to be outside. So that was kind of the push, I think, from what he described, to try the edibles. I don't think he's doing it every day, but he is trying out new products. And so I don't think it's a maintenance as much as let's try this for a while and then he'll be off of it. I get the impression that it's intermittent, but over time there's a consistency. When you look back through the decades, there's always been this effort to use the product.
Thank you.
Yeah.
Thank you. And then AKERSCS. You have a hand up?
Is that Cynthia?
Cynthia? Do you want to unmute yourself? There you go. You have a question?
If I'm wondering if he's using CBD products or if he's actually just smoking marijuana, because a lot of the CBD products, you can get over the counter, and a lot of them have different levels of THC in them and are used for various things. So is You know, is he just smoking marijuana?
Well, I think that he was mostly smoking marijuana over the years, over the decades. And then as these new products became available in the last couple of years, he has dabbled and reached out. I haven't talked to him specifically about the different types because I wasn't aware that there were difference. I thought that there was CBD products, and I cautioned to make sure that the THC wasn't in there. But beyond that, I don't think that there's been a specific type that he's been focused on, just trying to find something that works for him.
Karen?
Yeah, hi, everybody. I'm driving, so sorry if I shout at you. Yes, Karen, I'm the caregiver representative. What you said about word of mouth, definitely that's the situation with the CBD. Everybody in the dementia community is turning towards CBD, and driven a lot by the representative from the Veterans Administration talked to us. And that's interesting because there's obviously a lot of PTSD, and it's mostly wives, but the spouses of these veterans, they're all over it with the CBD gummies to manage anxiety and PTSD. And of course, in the VA system, the doctors there can't even talk to them about it because it's federal. But they all kind of feel like they get the wink, wink, try it if it works. You know, go for it. We're in Washington State. And so my spouse, who's not a veteran and doesn't have PTSD, was developing increasing anxiety as the dementia progressed. And so, you know, again, it's like, how do you dose this? He was a physician, I'm a nurse practitioner. I want to know all about dosing and side effects and contraindications and blah, blah. Well, of course, that's not out there. So I got as much information as I could from the people in the support groups who told me how they kind of started with small doses and, you know, change things over time and what works for them and which brands they like, yada, yada. And then I'm in urban Seattle. And so I just started going to all the pot shops, which you're not supposed to call them that anymore, cannabis outlets, and talking to the people who work there. And after doing this for a couple, 3 months and talking to probably 12 or 15 people, some of whom are not informed at all. I went in and said, I'm looking for a CBD product with 250 milligrams per gummy. And or no, I was saying, they tell me 97% CBD and 3% THC, because you have to have some THC to open up the cells. The receptor needs a little THC for the CBD to get in there, is what I'm told. But obviously you don't want THC for mind altering effects, especially in somebody with dementia. So anyway, so I said, I'm looking for 3% THC and 97% CBD. Do you have anything? And the kid was like, well, we don't sell it like that. We sell it in milligrams. And I'm like, well, I know, but we can do the math. And I got my phone out to do the calculator. And he was like, no, you can't do it like that. So anyway, so that was one experience. But in some other shops, there's some really knowledgeable people who can talk about p-values and talk about confidence intervals and talk about, you know, I have my doctoral degree in nursing, so I can talk a bit about research statistics like that. And so I glommed onto them. And they were super helpful. I found some products that worked for my husband just when he'd start spinning out of anxiety, apprehension, control. I could just pop one of these in his mouth, even though we were on a no sugar diet. At first I was sucking the sugar off the gummies, but then whatever, you know. And for the most part, it was really effective. And then in early February, I did place him in a memory care facility. And they gave approval for his PCP. It's not prescription, but you can authorize. And so I had to buy the gummies because obviously you can't get them through Omnicare or pharmacy or whatever. But if I bought them at a shop and brought the package in unopened, they would put it in his little drawer and have the PCP's order for, you know, 250 milligram CBD gummy, blah, blah. So that was, I thought, super cutting edge. And then the other thing I'll say is for sleep. So my husband just became this terrible sleeper. I called him the night stalker, which is common with dementia. And the CBDs for anxiety, I found out, not sleep. There's another compound called CBN. I don't remember what it stands for, but there are drops you can get in, like, you know, your typical dropper bottle that has CBN, CBD, and again, a tiny bit of THC, because you got to open up the receptor. And the CBN is magic for sleep. When I started just squirting that into my husband's mouth right before he went to bed, he slept so much better. So I feel like I'm sort of just this explorer in this area, and willing to try some of these things, and am pretty impressed with some of the effects, and so far haven't seen any untoward effects or anything. But anyway, that's my experience in this world that I've probably been dabbling in for about
Thank
a year.
you. Yeah, thank you, Karen. And I mean, I think, you know, you're speaking to, it's a bit uncharted and kind of, it's very empiric, and there's unanswered questions. And I'm happy to hear in your experience that it has been helpful and in different ways and different preparations. And Chris, you have a comment or a question?
Yeah, I think it kind of ties some of this together, and Mimi's question of, what does working mean, right? What is it? Have you asked him, what he likes about this, whether it was smoking marijuana for decades, or, why he continues to kind of reach for this? I think about some of the harm reduction or the motivational interviewing work around, what do you like about this? And why might you not do it? And I also was wondering, I think your theory about self-medicating distress is probably spot on, or boredom, whatever it may be. Has he ever thought about psychotherapy, or is that an option?
He has been given several opportunities to seek out any type of counseling, and financial resources are not a problem, but chosen not to. And I just am looking from the inside out, or from the outside in, and making some assumptions about the use. Now, he's of that generation where in the 1970s it became 80s, or 1960s and 70s it became socially acceptable, and so he's that kind of generation, but has continued it on where maybe some of his peers did not. I've never come out and just bluntly asked why are you doing this, and I don't know why I haven't done that. That is a very valid thing to just do. I want to give as much guidance as I can, because I think this is a good alternative to a some other kind of standard anxiolytic prescription that will never be filled. He'll be very polite about it, and he might even take the prescription suggestion, but we'll never fill it. So yeah, I think there's maybe another session with some discussion to ask, what is the goal? What does he think has been going on over these years where he's used that? There is quite a bit more focus on end of life. Death is approaching. Many of his peers have passed on, including people that are far younger than him. So I see that anxiety further increasing.
The existential anxiety, it sounds like. Karen Clay, please. Hi.
Hi there. Hi, just a couple of questions given as intermittent for recall and confusion, and also that he's bought these extra supplements. I was just wondering, does he already have somebody providing some financial oversight? And then I was also wondering about, is somebody helping him manage his medication / supplements? So is he kind of able to do that safely? And it sounds like he's kind of an independent living situation.
Yeah, he did reluctantly agree to some financial oversight by family. And that happened with moving into the retirement community. But there is nobody able to oversee his daily med admin. He still labels himself as fiercely independent. So that is a service that could be brought in. Again, finances are not a problem. For something like a visiting angel to come in and just make sure, but I don't know that he would go for that. It's certainly something to ask. Right now, he's keeping track with little sheets of paper and tracking. He has to because he self-casts. So, and he has the eye drops for the glaucoma. So he is trying. He has various coping mechanisms for trying to remember that. Yeah.
Thank you. Deborah, you mentioned too that all his routine blood work was normal, and it's likely with all his nutraceuticals that he's getting B12, but with his very strict diet, was that something that was recently looked at? Because that certainly could contribute.
Yes. So last year was the hypertensive crisis / TIA, and everything was looked at again in close detail. He was a little low on the B12 and was given a prescription for B12 and chose not to fill the prescription. I think he got it from an alternate source. He buys most of his supplements through a food co-op. But you can see this focus on not wanting to take anything from a standard dispensary. I don't think that B12 is an explanation right now for this. He was low, but still within range. And since he's moved into the retirement community, his diet has stabilized where he's fed up to 3 meals a day. And he does take on average, maybe 2 of those. And he's probably gained back about 5 pounds, which he was down, I think, to 125. So he's 5'5", 5'6", something like that. So fairly, a good that he's going in the right direction, but he's feeling like, that's maybe too much for him. Yeah.
Cynthia, do you have your hand up? Is that do you want to ask another question or have a comment to share?
No, I'm sorry. I didn't know my.
That's okay. That's okay. All right. Deborah, do you have any more? So it sounds like really how to kind of meet him where he is and give him the best guidance and support that you can provide. Trang, is there anything you'd like to add in the last couple of moments?
Yeah, I would just want to add, because he's 86 years old already, if he wants to do it, then we want to also talk about some of the side effects, adverse reactions that he's going to run into, because all these CBDs have psychoactive ingredients in it, so it can make him more confused, increase more risk of falls, and it may or may not be helping with his anxiety too, because that sometimes can worsen the so if he chooses to do it, I would recommend counseling on his, just because of his age, condition, and the side effects of his medication. I also have one more question. You mentioned that he's taking other supplements. Is he on St. John's wort?
No, I think I might have left out turmeric, but he is not on that. In fact, I believe he and I have talked about that medication or that supplement and how, if he ever chooses to add it. So please let me know so we can talk about the risks of that.
Thank you so much. All right. So it is 1:30. And so next Echo on March 24th, we have Dr. Sumijaya Dev, who's going to speak with us about neurogenetics and neurodegenerative diseases. Thank you so much, Deborah, for that wonderful presentation. And please do take a moment. I believe in the chat, you'll find the after visit, survey to complete. Thank you all, and we will see you in the next, in 2 weeks. Thanks again. Thank you, Deborah. Thank you, everyone.